Welcome to our Take Control webinar, Mouthcare Matters. Um, I am happy to have you all here and this amazing topic. We have with us speech language pathologist Sarah Awde. She has been a speech language pathologist since 2004 and then working the last few years exclusively with Parkinson's patients. And I have heard so much about Sarah over the last year or so from, if any of you know Nate Coomer from the Parkinson's Fitness Project, every time I go there, he says, have you met Sarah yet? Have you met Sarah yet? And finally, I get to meet Sarah. She has been a huge asset working on this program. She's done a newsletter she's working on a newsletter article for us, and we're just really happy to have her here. I also want to do a special thank you to Kiawa Corinne, who is our sponsor of this program. And without them and all of you who donated when you registered, these types of programs wouldn't be possible. So thank you very much for all of your donations and Kiawa Corinne for their sponsorship of this program.
Okay, well, welcome everyone. I'm so excited to be here, and thank you so much to American Parkinson Disease Association Northwest Chapter for having me. It is an absolute honor. This is actually one of my favorite topics to cover as a speech pathologist. I worked for 14 years, 14 years in acute care hospital setting. And I did a lot of mouth care. I actually had the title, the oral care queen, in my hospital. So I don't know if you can see the crown up there, but you can just imagine that it's up there. So this is, I think, one of the most interesting topics because it's not complicated. These are things that everybody can do to reduce their aspiration risk. It's not expensive, it's not complicated. So I really hope that by the end of this talk, this webinar, that you will be equipped with the tools, the knowledge, and the confidence to do everything that you can to significantly reduce your or loved one's risk of developing an aspiration type pneumonia. So let's continue on here. Jean, thank you for that introduction. Yes, I am a Canadian speech pathologist. I worked for many years in many sectors of healthcare, most acute care, but more specifically, only with the Parkinson's population. I really, really enjoy working with individuals with Parkinson's on communication and swallowing. And this inspired me to create something that was very much needed. It's a program called Get Loud, Stay Loud. It is specific, Parkinson-specific speech and voice exercises to optimize, to maintain, to improve both communication and swallowing function. And we'll get into why that is super important and why those types of things are also part of the things you want to be doing to reduce your risk of aspiration. So what are we going to cover today? And I know I'm covering some of these words here. So by the end of this hour that we have together, you will know what is aspiration pneumonia, who and what population is at the most highest risk of developing this type of pneumonia. Why is oral care, mouth care, particularly important for those with Parkinson's? How can you yourself implement an effective oral care routine, either for yourself or a loved one with Parkinson's? I've got my best tips and tricks to reduce your risk of aspiration. These are things that I have honed and learned over almost 20 years of being a speech pathologist. I was saying to Jean and Kirsten that I started when I was 12, so that's why it seems like such a long time. And of course, at the end, we'll have a question period. I'll do my best to answer your questions. If I don't know the answer, I have a huge network of colleagues that are very, very smart, and I will do my best to find out anything that I can't answer for you. So let's jump in. First, let's learn about what is aspiration pneumonia. And I'm going to be sipping on water. As I said, it's very dry here. So I have a very dry throat today. Aspiration pneumonia is a specific type of pneumonia that occurs when something that you ingest, whether that's food, liquid, medication, it can even be your own saliva or vomit that comes up the wrong way. When that makes its way into the lungs, of course, we do not want anything like that in the lungs. So when anything foreign like that makes its way down the wrong pipe, so to speak, That's called an aspiration event. And if the circumstances are ripe and there's bacteria in any of those things, that can develop into what's called an aspiration type pneumonia, which is a specific type of pneumonia that is related to those things going down the wrong way. So what are the symptoms? And these are really important to watch out for, because if you have a suspicion that you might be developing an aspiration type pneumonia, you really want to make sure that you get seen by your primary care physician as soon as possible. You want to get in there so you can get the assessment and get started on those antibiotics as soon as possible. So these are just some of the symptoms. You might present with a few of them, all of them, but they are all related to aspiration type pneumonia. Fever, feeling very fatigued, a cough, feeling short of breath, having difficulty swallowing. It can actually contribute to more difficulty swallowing, feeling some chest pain, sweating, and if you start to notice a bluish tinge to your skin, which of course would indicate that you're not getting enough oxygen into your system. So what will typically happen is you'll see your doctor, they will do an assessment, they'll listen to your chest, they'll check for all of these symptoms, and more than likely they will do a chest x-ray, and they'll be looking for a pneumonia in any of the lobes of the lungs. And on this, you can see there's kind of a white hazy opacity that gives an indication that there's something brewing there in the lungs. And doctors also can have a good guess of whether it is an aspiration type pneumonia by where in the lungs it's located. So because of the way we're built, aspiration type pneumonias tend to happen most in the right lower lobe. So if they see right lower lobe, someone that has maybe a history of swallowing issues, they're going to be pretty certain that that's an aspiration type pneumonia. Now, why would it go to the right lower lobe? Well, it's how we were built. So you have two bronchi that come down into the lungs. The left bronchi isn't at a very sharp angle. It's kind of, a gradual descent. The right bronchi, and I'm exaggerating, has a more direct vertical line down. So you can see gravity would make it more likely for something to go down the right bronchi into the lobes of the lungs. And of course, that will depend on your positioning and how you were sitting or lying down when that aspiration event happened. But if there is any suspicion that there could be an aspiration type pneumonia brewing, your doctor will more than likely start you on a course of antibiotics as a precaution, even if there's not full-blown pneumonia happening yet. If there's a suspicion that it could, and if you are really, especially for a person that's quite compromised medically, they will start them prophylactically on that course of antibiotics. So how long does aspiration pneumonia typically take to develop? The symptoms of aspiration can start very quickly, even as quickly as 1 to 2 hours after you have something go down the wrong way. And sometimes it isn't just one event that happens, like you had a bite of something and it went down the wrong way. Typically, it's little micro aspirations that are happening on a regular basis, and sometimes just it hits a tipping point where, oh, no, there was too much bacterial load in that, or just too much went down the wrong way. We'll talk about those types of things in a later slide. But then it takes usually a day or two for that pneumonia, that consolidation to happen in the lungs, for the lungs to fill up with that fluid and turn into that full-blown pneumonia. So you definitely want to, again, seek treatment as quickly as you possibly can. So we mentioned the word dysphagia. If you haven't heard the word dysphagia, it's just the medical term for someone that has difficulty swallowing. So dysphagia equals dys, which is disordered, phagia meaning eating. So why is swallowing impairment common in Parkinson's? So why would that happen in Parkinson's? I'm going to bring you back to what happens in Parkinson's. There is a dopamine deficiency in the basal ganglia, which impacts certain motor movements. There can be tremor, all this, rigidity, slowed movement, And what I find the most prevalent throughout all systems is smaller movements. And it's often referred to as the disease of low amplitude. And we know that from reduced arm swing, maybe a smaller step, that kind of short shuffling gait that's very typical in Parkinson's. There's also difficulty initiating movement. Pardon me. So you might have trouble kind of getting that first step going. And once you get going, you get into a pretty good rhythm, but there can be difficulty with that initial onset of movement. And then there can be difficulty with coordination of movement. So when we think about all these things that happen in Parkinson's, we tend to think of them on the gross motor scale, like arm swing, length of stride, all the kind of big body movements that become reduced. But we have to remember that all of those smaller movements and those movement impairments also happen to the smaller movements, such as facial expression. So we know that facial masking is very common in Parkinson's, that sort of flat, expressionless look that is quite typical, that can progress over time. And again, that's back to that disease of low amplitude. Your brain thinks that you're making big movements with your face, you're animated, you're smiling, when in fact smaller movements are happening, and there's a faulty feedback loop. So your brain doesn't say, Sarah, you didn't really do a big smile or eyebrow raise in response to that person. Your brain tells you false information, so you don't correct it. So think of it in terms as well of speech movement. So speech can become maybe slurred or less clear. Your voice even can become smaller. That's actually one of the biggest complaints that we get as a speech pathologist. I used to have this strong booming voice, but now people are constantly asking me to repeat myself. I feel I'm speaking perfectly loud, but I'm clearly not, because no one can hear what I'm saying. So again, disease of low amplitude, it makes all of those systems, the voice, the articulation, and yes, even the swallow, reduced in amplitude, reduced in coordination. So that makes sense when you think of it that way, that if you get problems with smaller movements when talking and smaller movements when swallowing, then communication and swallowing impairment can occur, especially as into the mid or later stages of Parkinson's. So these are just some of the typical things that you see, communication issues, the slurred mumbled speech, the quiet voice, even the reduced prosody. So small sort of intonation in the voice. Voice can become very flat and robotic sounding. Even reduced fluency or pacing of speech. So there really isn't any aspect of communication that it can't affect. So I was going to get fancy and try to draw on my thing here, but I can't figure out how to do that. You'll have to bear with me. But I wanted to kind of explain what happens when you're swallowing and why would something go wrong. So hopefully you can see my arrow here. But when you bring anything into your mouth, a liquid, maybe a puree like an applesauce or something to chew, your brain has a very automatic set of movements that you've done from the time that you were a baby on how to control that substance, whether it's a liquid that moves very freely and very quickly, or something that requires chewing and moistening and then forming into a nice ball and then moving to the back of your throat. So if you have trouble with even coordination, even a little bit, very slight coordination of kind of tongue movements, jaw movements, if you have difficulty kind of initiating the front to back movement of the food in your mouth, if you have trouble initiating the swallow where the larynx rises up to protect the airway and back down, you can see how it would only take very slight impairment in those movements for something to go wrong. The swallow is a very finely timed mechanism. And so if even something's off by a fraction of a second, it's easy for something to go down the wrong way. And we've all had that happen, Parkinson's or not. We've all been chatting, socializing, not paying attention to what we're doing, and something goes down the wrong way. Your body does a big booming cough. But it happens. The reason is because, again, it comes back to the way that we're built. No judgment, but we were built with the airway and the food tube being right beside each other with a big old shared opening on the top. So here, if you can see my cursor, this is the airway where that arrow is. And then the food tube is right behind it. Okay. And then this whole part here, wide open. Okay. And when you swallow, your body has to do a complex set of movements to make sure that that airway is closed and moved out of the way of the path of the food so that everything is directed down the food tube into the stomach and that nothing kind of diverts down the wrong way, which is an aspiration event. And of course, if that makes its way to the lungs, that could, not necessarily 100% will, could develop into an aspiration type pneumonia. So we want to make sure that we understand how a swallow works, to understand what could go wrong with the swallow, to then buy into what do I need to do to optimize my swallow function. And one of the handouts that, it's the 3-page clickable handout that the ladies will be sending you, is a swallow, the normal swallow. I've got a short video on there about what is the normal swallow, what is involved. That's a really good watch. And then there's another one there that has some swallowing exercises. So yes, as Parkinson's progresses, more difficulty with swallowing can occur, and it can occur in the mouth phase, the throat phase, or even the food tube, the esophageal phase. So it's there are different types of swallowing disorders. Not everyone presents the same, but it is fairly common for swallowing issues to occur. Like I said, more in the mid to late stages of Parkinson's. Okay, make myself smaller again. So what are the swallowing issues that we see most in Parkinson's? The first one is difficulty controlling food and liquid. So there might be spillage of food and liquid, especially things that are really runny or not easily controlled in the mouth. Or even just stuff kind of being stuck in the pockets of the mouth. So instead of being controlled in a nice ball, things kind of fall into the little sulci of the cheeks. Difficulty with timely and efficient bolus formation. And when I say bolus formation, I mean taking that bite of sandwich, lubricating it, chewing it up, and then forming it into a nice mushy ball in order to swallow it. Difficulty transferring food from the front of the mouth to the back where it's going to be swallowed. That can be either delayed, trouble initiating it, or just less controlled. Difficulty clearing food that's supposed to be not foo. Difficulty with clearing the stuff that falls into the pockets. There can be like little bits of food and crumbs and things like that really get stuck, especially in dentures. Dentures are particularly bad for that. Difficulty with triggering a timely or a strong swallow. And it really, we do rely on that good, strong swallow, again, to move the airway out of the way of the path of the food, and also to get good propulsion to push things like bread or a piece of meat, something that's a little bit more stodgy, down your food tube and into your stomach. Some people have trouble clearing. Once they swallow, they still feel that they have food or liquid stuck in their throat, kind of like that, oh, I got a candy stuck there and I just can't get it out. Food and liquid going down the wrong way, and we'll review what those signs of aspiration are. In Parkinson's in particular, are at increased risk of what's called silent aspiration. Silent aspiration is when little bits of food and liquid go down the wrong way, and there is a reduced sensitivity, awareness, and response to it. So instead of your body doing that effective, healthy, strong cough to expel it out of the lungs or the airway, there's no reaction. Okay, and I've seen this many, many times on video fluoroscopic studies. It's usually small amounts. Usually if there's a big amount that goes down, it triggers a response, but little drips of fluid, little bits of here and there. It is quite common in Parkinson's to have that silent response to aspiration. If there is a response, sometimes the cough is not effective and strong in order to expel whatever has gone down the wrong way. So these are just kind of the common things that I've seen over the years as being the most difficult with respect to Parkinson's. So how do you know if you have a swallowing problem? I won't go through all of these, but just have a look at the screen, see whether any of these jump out at you. The biggest ones, of course, are if you're coughing, spluttering, choking during or after meals, especially with liquids. That's a big one that many people have trouble with. If you're noticing a change in your voice, this one not many people know about. So after you eat or drink, if you notice a wet, bubbly, kind of underwater sound to your voice, what's happened is something has gone down the wrong way, and in your airway lie the vocal cords. So if something passes over the vocal cords like liquid or applesauce down the wrong way, it's going to give you kind of a wet, bubbly sounding voice. So there is an indicator of aspiration that you might not be aware of. And of course, all the other things that we reviewed in the previous slide. So it's important to know that the research shows that individuals that have any dysphagia, swallowing issue, swallowing impairment, your risk of pneumonia is 3 times higher, which makes sense. You have more things go down the wrong way, it's going to increase your risk of developing an aspiration type pneumonia. So what actually causes the pneumonia? Is it the French fry that went down the wrong way? Is it your cup of tea that you coughed and spluttered on? Are those causing that infection in the lungs? Most often, the real culprit for these types of pneumonia is not actually the food or the liquid entering the lungs. It's the bacteria in the mouth that kind of attaches to the food or liquid. And the food and liquid are just the vehicle that gets it into the lungs. So you can see where I'm heading with this, because I'll repeat this again. The real culprit is not the food and liquid. It's the bacterial load in the mouth that travels with the food and liquid down the wrong way into the lungs. So you can see why having a really good, pristine oral care routine, mouth care routine, is essential in reducing your risk of developing an aspiration type pneumonia. Reduce the bacterial load, less bacteria can make its way into the lungs, which is the real culprit for those pneumonias. And the research is very, very clear on this, that one of the most, if not, I think the most important thing to implement to reduce your risk is diligent oral care. And we'll go into this in more detail. It's the most protective thing that you can do. It doesn't cost a lot. It just takes a little bit of attention and routine. And it's quite simple. It's quite simple to do. So dry mouth. I'm talking about dry throat today, but dry mouth. Uncomfortable, annoying. Many, many people with Parkinson's suffer from dry mouth. The medical term for this is xerostomia. And it's a combination of insufficient fluid intake, perhaps due to difficulty swallowing. Of course, if you're having trouble with liquids, you're probably not going to be taking as many of them. In general, most people tend to not take in enough free water, liquid during the day anyway, which we'll talk about. And then the second reason are medication side effects. There are many, 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 probably the most common side effect for many medications is that dry mouth. Very, very uncomfortable. But more than that, it is it's a health risk, and we'll talk about why that is. So saliva, the power of saliva. Saliva is really a fantastically wonderful thing. It does many, many things. And the saliva, you can see in this diagram, are produced by 3 main salivary glands: the parotid gland, the sublingual gland under the tongue, and submandibular gland, mandibula, under the chin. So what does saliva do? Saliva helps not just to mechanically lubricate your food, make it nice and smooth and easy to push to the back of your throat and down the right way, but there's also something called salivary amylase in your saliva that chemically helps to break down your food. We produce about just on average, about 600 milliliters of saliva per day. And this constant wash of saliva that's happening helps to wash away any of that debris after we've eaten. And it also prevents bacterial attachment. So saliva has these microbial compounds, and you don't have to remember the names, but hydrogen peroxide, lactoferrin, and lysosomes that actually stop bacteria from attaching in your mouth, and it also helps to kill the bacteria. So this saliva does wonderful things to help reduce the bacterial load in your mouth. So really, that homeostasis, that nice balance, that yin and yang in the mouth of the oral cavity is maintained by saliva production. So it's not just uncomfortable and annoying when you get a dry mouth, it's actually risky. You're actually increasing your risk of trouble swallowing, for one thing. Try to swallow a cracker without any saliva and you'll know what I mean. And also increasing that risk of too much bacterial load, which, if gone down the wrong way, can contribute to that aspiration pneumonia. So I won't go through this, but these are just the wonderful things that saliva does: antifungal, antibacterial, antiviral. The mechanical lubrication helps with food digestion, helps keep your teeth strong and healthy. And it also has wound healing properties. Wounds inside your mouth heal much faster than ones on the skin. And you'll know this if you've ever had a bit in your cheek, it heals quite fast. Because of that, these things that are contained in the saliva that facilitate and promote that wound healing. So saliva, good stuff, good stuff. Okay, so this is a handout that I made for my clients in particular, and I've shared that with APDA so they can pass it along to you. And you will get a clickable link. So all of these things that say hydration calculator or link to something, you'll be able to click that handout. So the number one thing you can do if you suffer from dry mouth is make sure that you are staying adequately systemically hydrated. I can guarantee that if you haven't, at least for a 2-week period, done a water tracking, you are probably not getting enough fluid. We all tend to think that we drink enough during the day. I had a big glass of water with my pills. I had a cup of tea and 2 coffees, and I had a bowl of soup for lunch, and I sipped on water all day. You'd actually be surprised. I did it, and I was very surprised that I actually wasn't getting enough hydration. So I have a link here to just a generic hydration calculator. It's not medical advice, but it can give you a little bit of an idea of, for your age, your gender, your medical status, what is a ballpark of a good amount of water that you should be taking in. Now, just a caveat, if you have kidney issues, your fluid intake might be less, the recommendation, because of your renal issues. So if you are going to significantly change your fluid intake, make sure you check with your doctor or your dietitian to make sure that that's appropriate for you. The second thing you can do is try to limit caffeine and alcohol, as these have very dehydrating effects. The third thing is check with your doctor. Are there any medications that you're on that have a significant side effect of dry mouth? Maybe this one was really bad. They can suggest an alternative, or perhaps a lower dose, to see if you can negate that dry mouth side effect of the medication. Something that I live by, because we live in a very dry area of France, it's a wine producing region, which is fantastic, but is very arid and it's very dry, is running a humidifier. If you don't have it built into your house system, you can just buy humidifiers, especially at night. That's a good time to run a humidifier and just breathe in that nice, moist, humidified air, especially during the winter months, which can be a lot drier. There are oral rinses and sprays that you can get from your local pharmacy. Biotine is the one that's most often seen or recommended. And there are actually these gums and candies that help to stimulate saliva production. And there's a product called Xylamelts, and it's a clickable link in your handout as well. They're like a little disc that you just adhere right up here on the gum line. Okay, and you can actually wear them overnight, and they just kind of have a slow release effect of stimulating saliva production to help, if the issue is that you're not producing enough saliva. The only thing I would caveat is if you're not systemically hydrated, if you just don't have enough fluid in your system, they can kind of make sticky, pasty saliva. So you want to make sure that your hydration status is very optimized before you try something like Xylamelts. If you have an issue with really dry, sticky, tenacious phlegm in the throat, you just feel like you got a wad of something in there. A lot of people have that issue, especially if you have xerostomia, dry mouth. Try pineapple or papaya. Both of those fruits have natural enzymes that help break down thick phlegm. You can also try pineapple or papaya juice, but you just have to make sure that it's 100% pure and not like pineapple drink, which will just be sugar and flavoring. So pineapple, papaya, fruit or juice, and just take that when you're feeling that you have that really thick, tenacious phlegm that you can't clear from your throat. And again, you'll have this little handy handout. Okay, so what are the oral care recommendations? So the literature is varied, as always, and anywhere from 2 to 6 times per day is recommended for 1 to 2 minutes. The average seems to be about 90 seconds. So, and I'll explain what I would recommend. So why is it advisable? We typically think of, we'll eat a meal and then I'll brush my teeth after. Why is it advisable to do mouth care before a meal? If you think about that problem of bacterial load, let's say you get up in the morning and you think, well, I'll just have my breakfast and then I'll brush my teeth. Meanwhile, all night, you've just been breathing in, breathing out. And of course, as we breathe in and breathe out, there's just, bacterial microorganisms that kind of float in and out. And those are building up all night. Now you're going to go have your breakfast. And if you have any swallowing impairment, you might have a little bit go down the wrong way here and there. And if you haven't brushed your teeth or done any mouth care before your meal, the bacterial load in your mouth will be quite significant. But if you just take that 1 minute, even if you don't want to do a full 2-minute brushing and flossing and the whole 9 yards, if you even just do a really quick swish and spit with a good alcohol-free mouthwash, maybe just scrub your tongue, swish and spit, and then go and have your breakfast, or drink a glass of water first and then have your breakfast. That will go a long way to just making sure that you're starting that meal with the least amount of bacterial load in your mouth. So the recommendation for oral care is always greater. So you want more frequent, severe, thorough oral care. The higher you are, the higher risk you are. So the more frail, the more immunocompromised, the more, and we'll explain all the different risk factors in a moment, but the higher the risk, the more oral care needs to be done. So mouth care routine: use a soft bristled toothbrush. Replace your toothbrush regularly. They get pretty bacterial laden. Use toothpaste, don't just use water or baking soda. You want to brush your teeth, your gums, and your tongue. And then you want to swish and spit with an alcohol-free mouthwash. So why alcohol-free? Again, alcohol has a very drying effect, and that can make that dry mouth feeling worse. So always look for an alcohol-free mouthwash. If you have dentures, you want to make sure that you are at minimum brushing your dentures in the morning and in the evening. If it's a care home, a long-term care setting, nursing home setting, you want to make sure that the dentures are labeled appropriately so that they don't go missing. And you want to, when the dentures are out, you want to still take some time and brush the gums, because it's on all the little surfaces of the gums that bacteria can adhere to as well. And then you want to, most important, make sure to regularly clean and disinfect the denture cup, because that can also build up with yucky film and bacteria. I can tell you that whenever I had patients come in the hospital from nursing home, I had a few horror stories of situations where clearly oral care wasn't being done for, I would say, weeks, if not months on end. And it's a real risk factor. It's a real risk factor, especially for people in long-term care that are maybe more medically compromised. They can't do their own oral care for either physical or cognitive limitations that they have. They're not able to do their own oral care. When it's left up to somebody to do, that's when more risk comes in, because it tends not to get done. It tends not to get done. So who is at risk? And that the reason I have a scale here is all of these things are risk factors that contribute to low risk or high risk of an aspiration pneumonia. So your general health or medical status, how immunocompromised you are, that's going to put you more at risk if you are more immunocompromised. If you have reduced mobility, so if you don't move around a lot, either because of just lifestyle or physical limitations, you have a more sedentary lifestyle, or if you're bedbound, obviously that's nothing you can do about that, but that does put you at higher risk, because when you're not moving around, when you're not active, and when you're not getting that constant air exchange in the lungs are kind of sitting prone, ready for infection. Being on multiple medications, as many of them can have different contributing factors to swallowing and dry mouth. As I mentioned before, if you are dependent for oral care, if you can't do it yourself, and if you can't even advocate it because of a cognitive or a language impairment, that can really put you at higher risk. Just your baseline dental status, if you happen to have a lot of cavities, if you don't visit the dentist very often, obviously that's going to put you at risk for more bacterial buildup in the mouth. And just your general medical history. Do you have, were you a smoker? Do you have COPD? Do you have underlying lung issues? Did you have cancer? Did you have a lobectomy? All of those things. And then there's also this general factor that I just call luck of the draw. There are some people that aspirate all the time. They aren't moving around very much. They never get an aspiration pneumonia because they're just not susceptible to them. And other people aspirate very, very little amount, and then they just are prone to pneumonia. So there's just sort of that medical genetic makeup that can be that that factor that is just the way it is. Nothing you can really do about that. So it's important to know that risk of aspiration pneumonia can change. You might go 20 years with Parkinson's and never have an issue. You maybe have a mild swallowing impairment, but you have a good cough response, never developed a pneumonia. And then perhaps you develop an acute illness and you end up in the hospital and you're not moving around as much because you're sick. And then maybe your mouth care goes out the window because you're not at home. So any of these things can shift, and the balance can go from low risk to high risk. So it's important to try to control the factors that you can control, but knowing that there's always going to be factors that you can't control. So focus on the ones that you can control. So just a note about people that are in hospital or nursing home setting long-term care. As I mentioned, those in long-term care, those that are dependent for oral care, are at highest risk of aspiration pneumonia. And this is often due to lack of oral care being done in these settings, either due to staffing shortages. We know nurses and care workers are overwhelmed. It often, unfortunately, falls to the bottom of the nursing care to-do list, because either I don't have time to do it, so I'm not going to do it, or it's seen as low priority because they see it as more grooming, like brushing your hair, not as a medical intervention, which it is. It is an absolutely important, essential medical intervention. So there's no excuse as to why it's not done, but I can tell you from 15 years working in different acute care, rehab, home settings, that it often doesn't get done. So, and there's also people that just don't like doing it, so they don't do it. And it compounds the issue when the patient or the client doesn't have the cognitive capacity to advocate for themselves to have this oral care done. So this is why I really encourage, if you have a loved one, a friend, family member that's in hospital, that has Parkinson's, that maybe can't advocate for themselves, that you be that advocating voice for them. You check say, was Mouthcare done this morning? Did Bill get his dentures cleaned? Whatever. If you feel comfortable doing it, not everybody does, but if you feel comfortable, that is a wonderful thing that you can do. Sometimes people visit friends and family in hospital and say, I feel so helpless, I can't do anything. That is absolutely something that you can do that will make them feel better, make them feel more human, improve their quality of life, and decrease their risk for aspiration pneumonia. So just a note on, sometimes there can be challenges doing mouth care with individuals, especially if they're in the later stages of dementia. And there can be a complete resistance, clamping the teeth shut, clamping the mouth closed, not letting the toothbrush in. And you have to understand, from a person's perspective that has dementia, that they're no longer processing what the purpose of these everyday activities are. So when they see something coming at them, they feel panic, invasive, their primitive brain takes over and says, no, there's a threat, I need to shut it down. So it's a very normal response if you think of it from that perspective. They don't understand what the purpose of doing that's good for me. It'll feel better. I'll be healthier. I'll have less risk of aspiration pneumonia. So you have to understand why it's happening, and then implement some strategies to help facilitate their comfort level with that. So these are my suggestions. Make the environment as ideal as possible. If you can, try to make it the same routine in the same place, in the same location, so it just becomes that really ingrained habit. Reduce all distractions, turn off TVs, turn off radios, limit people around. You don't want noise, because that kind of, not focusing on what you're doing with the mouth care, because they're distracted by other things going around. A calm, smiling demeanor, but don't use elder speak. So elder speak is speaking to a person, an elderly person, like they're a child. So you want to avoid elder speak. So establish a rapport before starting. Just start chatting and say, hey, June, that's a beautiful sweater you're wearing. You look really good in red. And just, that tone of your voice, even if they can't comprehend what you're saying, that feeling of comfort, that feeling of this person is not a risk to me is essential. And then just explain each step that you're doing, short and simple. Say it before you do it. So don't start at them with the toothbrush before you said, here's the toothbrush. I'm going to get you to open your mouth, and we're just going to do a little brush on the bottom. So can you open your mouth? And the biggest trick I've learned for helping people eat and to do oral care for people that are resistant to either of those is, can they do some sort of hand over hand? So let's say you have the toothbrush in your hand and you're doing it. If you can even facilitate a hand over hand and putting their hand in it, this action for them, doing it themselves, is a direct connection to the brain of brushing their teeth 1,000 times in their lives. You're going to get more compliance if they are participating in it, even if they can only participate minimally. So doing a hand over hand, you've got the toothbrush. Okay, let's open the mouth. Okay, here we go. That can go a long way. And that's also for feeding. If someone's resistant to taking a mouthful of food, if you can get them to hold that fork, hold that spoon, and get them to, even if you can even just guide it, you'll be amazed at how much acceptance you'll get from opening the mouth, because it's just that long ingrained pattern of, oh yeah, okay, I recognize this. This is what I do. I bring this here and my mouth opens up, and all is good. So try that hand over hand technique. Other things that people have recommended are using a really brightly colored toothbrush. You can get built up special handles if someone has dexterity issues. That would be a special order. You can use power brushes if it's just too hard to kind of vigorously brush like this, the automatic toothbrushes. You can get non-foaming toothpaste if they just don't have the ability to spit and get rid of that foamy toothpaste. You can get special dental floss holders to facilitate flossing. At the very least, if you just can't get any mouth care done, there's antibacterial sprays that you can do to kind of just reduce that bacterial load. And just a note about lemon glycerin swabs, they tended to be very prevalent in the hospital when I was there. Do not use them. They are very drying. You're better to just use normal saline on a swab or something else, just not lemon glycerin. They're very, very drying. If mouth care needs to be done in the hospital or at home in a bed, so they're in a bed setting, do what you can to shift them up in the bed and then get the head of the bed up as much as you can to 90 degrees. With the hospital bed, it's easier, they're automatic. If you're at home, try to use pillows to prop up your loved one. And then using just a little bit of a rolled towel behind the neck, so that, because when we're in bed, we tend to kind of do this and kind of lean back. So you want to make sure that the head is tipped a little bit forward. And the reason you want that is if you're doing mouth care, you don't want the head like this, because now you're brushing, and if they have any swallowing issue, things are just going to fall back the wrong way. So you want gravity to allow, if anything's going to fall out, better forward than backwards. So a little bit leaning forward and a little bit of a chin tuck to let things fall out the front. And like I said, that slight chin tuck posture just to let gravity do its job. And then you can also get a little basin if just to catch the drips. So mealtime tips and tricks, okay? So like I said, I think I mentioned this earlier, a quick swish and spit or brush before meals and snacks. Start the meal with a clean mouth, because then if anything goes down the wrong way, if you have a pristinely clean mouth and you have a big gulp of water and it just goes right down the wrong pipe, you're likely not going to develop an aspiration pneumonia. Water is benign to the lungs. If it doesn't have any bacteria in it, you're not going to develop an aspiration pneumonia. Ensure that you have ideal positioning, ideally up in a chair if possible, and a slight chin tuck posture. And the reason, again, if you're eating and drinking, if you have any trouble controlling food or liquid in the mouth, the gravity is going to keep it at the front and not let it fall prematurely down the back of the tongue into the throat. Take small sips and bites. Like your mother said, no talking while you're eating, because again, that's asking your mouth to do two different things at once. Fluids are often an issue because, again, they run quickly, they're thin, they don't hold their shape. They're the quickest things to go down the wrong way. So if that's really a problem, and if you're coughing and spluttering with liquids, try having your liquids either before your meal, when your mouth is clean, you don't have any cracker crumbs in your cheeks, and there's no bacteria, or after the meal. Okay, so you've finished your meal, you've cleaned your mouth, now you're going to consume your fluid. So whatever is that high risk item, consume it separately from the rest of the food and liquid with a clean mouth, and that will go a long way to reducing your risk. Careful with called mixed texture foods or two textured foods. And I'll explain in the next slide what those are. And again, clean the mouth after every meal, at least a swish and a spit just to get out all the crumbs and the bacteria. Try to stay upright for a good 30 or 40 minutes. You don't want to lie down and have things kind of backflow up the esophagus and down into the airway. So mixed textures. What the heck are mixed textures and why are they so challenging? So foods that have a liquid and a solid component together. So Cheerios with milk, chicken noodle soup has like the noodles and then the brothy bit. Fruit cocktail with a really thin syrup. Even something like a juicy piece of watermelon has the watermelon. We've all had that before. We're chewing a piece of watermelon. You get a little bit of the liquid that falls down the wrong way. So when there's discoordination in the mouth or in the throat, it can be harder to manage liquid and solid at the same time. So these items that have liquids and solids can be an increasing challenge for people with Parkinson's. So what do you do about it? Do you have to not have your chicken noodle soup? Do you have to avoid? Do you have to have oatmeal porridge for the rest of your life? No, you don't have to do that. What you're going to do is you're just going to divide the two. So let's say you have your bowl of cereal. Okay, so the first spoon, I'm just going to take the Cheerios and drain the milk off, okay, on the side. I'm just having moist Cheerios, so that's all that's in my mouth. The second spoon, I'll have just the milk. Okay, so then I'm alternating. I'm only ever putting a solid or liquid in my mouth at the same time. And this can be the same case with medications. Many people have trouble swallowing a pill with water because, again, you're asking your mouth to manipulate a solid item in amongst this free-flowing fluid. with a system that maybe isn't as quick and coordinated as it once was. So I mentioned this later in a slide, but a little trick is just coating in some applesauce, coating the pill in applesauce, coating it in yogurt, just to get rid of that two texture component and help it slide down a little bit better. Okay, so a little note about medications, and I hope I'm not going over. Okay, I think we're on track here. So many pills are large or non-coated. Many people without Parkinson's have trouble swallowing medication. If you are having trouble with a certain pill, you can ask your doctor or pharmacist for an alternate form, maybe a syrup or a smaller coated tablet. Can the pill be cut in half or even crushed? You always want to check, because some medications are what are called extended release. So it's that slow melting and release of it in your system that gives you that benefit. And if you crush it, you get the full dose of the medication right away. So never cut or crush a medication unless you've checked with your doctor or pharmacist that it can be done. Only take one pill at a time. I can't tell you how many people I know that just, I just take my pills in my hand and I just throw right down the hatch. Don't do that if you have swallowing trouble. One at a time with a sip of water or a coated in applesauce or yogurt. So key points. Here we are. Key points to minimize your aspiration pneumonia risk. Stay as active as you can, Maybe that's a chair fit class. Nate's program is amazing, offers a variety of different things, daily dose PD, that's specific to Parkinson's. So try to stay as active as you can. Get that good air exchange in the lungs, really reduce that risk. Maintain excellent oral care routine, including going to the dentist regularly. Make sure that you don't have any dental caries that are brewing. You want to stay on top of that. Stay hydrated. Make sure you're systemically hydrated. You're doing whatever you can. Check my cheat sheet on how to combat dry mouth. Optimize your medication with your primary care physician. You want that maximum benefit of it's giving me the best quality of life and reduction of Parkinson's symptoms with the minimum amount of negative side effects. Seek out a swallowing evaluation with an SLP if you're having swallowing issues, and start doing speech and voice exercises. The earlier, the better. So all of these things can be done sort of as prevention, okay? And I always like that expression that an ounce of prevention is worth a pound of cure. It's so much easier to prevent infections, pneumonias, decline, than it is to have that and try to work your way back from it. So I won't go through these, but you'll have this. These are just medications that can contribute to certain swallowing issues, dry mouth, trouble with coordination of swallow, things like that. This will be in your handout. As I said, see a speech pathologist if you're having trouble swallowing. They will do a clinical exam. They might do an X-ray swallow study or some other instrumental swallowing evaluation. And then they're going to recommend either postural changes, swallowing maneuvers, suggestions like I've given you at meal times. They might suggest a diet texture modification, and then they will likely suggest Parkinson-specific speech and voice therapy or exercises. So why exercise? Why speech and voice exercises? How does that have anything to do with swallowing? Well, this is the 2-for-1 deal. So Parkinson specific speech and voice exercises that you do not only target communication, but they also target swallowing function at the same time. So why is that? So the same systems are involved. And this is why speech pathologists got handed both communication and swallowing as our area of expertise, because they're the same head and neck anatomy, the same systems involved, same cranial nerves. So your respiratory system, your breathing, your phonatory system, which is your vocal cords, your laryngeal structure, and articulation, all the movements of the mouth muscles. You can see how they are both communication and swallowing related. You should start these exercises as early as possible to slow the decline of any communication and swallowing impairment. Remember that ounce of prevention is worth a pound of cure. And I have people that come to me and say, well, I don't need to do these yet because I'm not having any communication and swallowing impairment. My response is, that's amazing. Let's keep it that way. Let's keep you from declining. It is so much easier to keep the decline from happening than to be in a very impaired state and have to work your way back up. So If you're doing the home program or speech and exercises on your own, the recommendation is about 15 to 20 minutes per day. So this is where my program comes in and why I created it, because people don't know what exercises to do. They don't know how they should be doing them. It's hard to stay motivated to do them regularly. So we provide lots of options, 10 classes a week of Parkinson's specific classes, like 20 minutes each. And you can attend as often as you like and keep on top of it. Keep your voice strong, keep your speech clear, and maintain that good swallow function. Okay, look at that. How did I time that so perfectly? So questions, if anyone has any questions.
All right, we have a few here. Thanks, everybody. And thanks, Sarah. This was incredible. I've been here at APDA for 7 years, and I know you're sending the slides, but I have about 12 pages of notes. Great information. So we have one question here from Barbara, and she said, how does the body get rid of something that is swallowed into the lungs on an everyday basis that does not lead to so that it does not lead to aspirational pneumonia?
So if there is things that are, if you have swallowing impairment and you have little bits of food and liquid that are going down the wrong way, most of the time, like I said, there can be in the later stages where that cough response isn't there, but most of the time your body will do a cough response to expel it. That is your body's natural reaction to anything that enters the airway. Even dust, if you've had that experience where you just kind of inhale a little dust mote and you start hacking and coughing. So if you're not aware of whether you're aspirating or not, step number one would be see a speech pathologist and just be reassured. Maybe you're not having that issue. But if you have any concern about that, get that swallowing evaluation done, and then they can guide you specifically. I know that there's, and don't take this recommendation because it would be specific to this person, but there was someone that was silently aspirating that was determined during a video fluoroscopic swallow study. And the recommendation was for them to do a swallow and then do a purposeful cough, even if they didn't feel they had to. Now, you don't want to do that unless you have to, because again, coughing can be a little bit traumatic over time to the vocal cords. But that was a recommendation given to that person because they didn't know that things were going down the wrong way. So they were to do a purposeful cough. But yeah, number one would be get a swallowing evaluation if you're worried about it, and they can guide you specifically on what you need to do.
Great. And then Paul's has a question. Why do I have problems swallowing pills?
Well, some people are just bad pill swallowers. I am not a good pill swallower if they're very large. Most pills, some like calcium pills, a lot of the vitamins, they are not coated well and they're large. I don't know why they make them this way. So it might not be anything having to do with you. And the best indicator is, have you always had trouble swallowing pills, or is this a relatively new thing? If this is a relatively new issue, it could be that there is a bit of dysphagia setting in. And you want to get that evaluation with a speech pathologist, and they can give you those recommendations. In the interim, try this order of things. So before you take a pill, take a sip of water just by itself. Moisten your mouth. Make sure the mucosa in the mouth and the throat is moist. Then take your pill and coat it in a little bit of yogurt or applesauce, and then try one at a time, and then chase it with a bit of water. So try that, see if that works as an interim solution.
Great. Ginny has a question. What if food slides down into the stomach without swallowing?
That typically doesn't happen. I mean, if something goes down if something kind of escapes out the back of your mouth and into the throat, it's likely going to go in the airway. So you would know it. If it was a large amount, you'd be coughing. So the brain is pretty good at triggering a swallow. When something gets to a certain part at the back of the mouth, the brain's going to trigger a swallow. If anything does kind of fall back before the swallow, it'll be a little bit falls back, and then the swallow will get triggered. So a little bit might go down the wrong way, but things don't tend to just slide into the airway because there's on the top and bottom of our food tube, there's two very tight sphincter muscles. So they have to be pulled open by the swallow mechanism and then they close again. So it would likely just kind of slide into your throat and then down the wrong way, and then your brain would trigger a swallow and swallow the rest of it.
Great. Susan wanted to know if you have any recommendations for the best mouthwashes.
Ooh, an actual brand? No, because I've been out of acute care for several years, so I don't know what new products are out there. Also, I was in Canada. I don't know if the products are different. But if I can jot that down, I have many American SLP colleagues that still work in acute care, and they might have recommendations.
Great. And we can put that in the follow-up email that'll go out tomorrow.
And in the interim, maybe just check with your pharmacist and say, what's a good quality alcohol-free mouthwash that you recommend?
Great. Another question from Suzanne. How do I strengthen my coughing muscles?
That is that's an excellent question, actually. There are things called expiratory muscle strength trainers. So EMST devices. And there is a massively emerging pile of literature in the Parkinson population. I have a colleague, Tiffany Miskey, out of Utah, that swears that every hospital needs to stock these and get their Parkinson's patients on them, because they just it's like a little exercise device for your breathing muscles, which of course cough is just a really forceful exhalation. So if you can ask your doctor, ask a speech pathologist, even better, about EMST devices, expiratory muscle strength training.
Great. Mark wanted to know if you recommend a modified barium test.
That is often done, and that would be up to the speech pathologist that you see. They might do a clinical assessment first, which is just the bedside assessment where they test your cranial nerves, and they might have you swallow some things. And then the gold standard of a swallowing evaluation is the modified barium swallow. So that's something you can certainly ask for. And I would certainly do that with any Parkinson client that came across my desk, is because of that risk, that factor of silent aspiration. I would think that swallow test would be always indicated. So definitely ask for that.
Great. And another one, Jim and Marcia, is gargling dangerous?
Depends. So if you have really good mouth control and you don't have any swallowing impairment, not so much. You can probably tilt your head back and have that liquid floating around back there and doing that gargle. If you have difficulty with control in the mouth, or you have especially a moderate to severe swallowing impairment, it might be tricky. I think that would be up to the speech pathologist that saw you to determine. If you want to swish and spit and you're worried about things escaping, you can always kind of do the head tilt forward. But again, that's not going to get, like you say, that's not going to get the posterior part of your mouth and throat. But yeah, it's perfectly safe if you don't have any swallowing impairment, but could be dangerous if you do have swallowing impairment.
Great. We have a few questions about phlegm. So,
my favorite topic.
I know. So I'll read all three, and you can probably combine them. A thick, sticky phlegm builds up inside my mouth. How to control it?
Yep.
And then another person asked, I spit out a lot of phlegm in the AM and before bedtime. Anything to take/inhale to facilitate the removal of this stuff?
Yeah.
And lastly, there was one, I'm going to butcher this, is gufenicin good for thinning phlegm?
The third question, I'm not familiar with that medication or that product. So
I might have butchered the name. GUAFENISON.
No, I haven't heard of that, but again, I've been out of the acute care hospital for a little while, but certainly check with your pharmacist or doctor if that is good for thinning out phlegm. I would say for the other aspects of In general, if phlegm is an issue, if you have thick, sticky phlegm and it's a problem whenever it's a problem, check your hydration status. Thick phlegm will be thick typically if you're underhydrated. Okay, it can't thin it out enough. So number one, track your hydration. See if you're getting in enough fluid to keep you systemically hydrated and producing enough saliva. And then number two, try the papaya or the pineapple, either chewing on bits of fruit, or if you can find that pure juice and it has that natural enzyme in it that can help to break up that thick, sticky, tenacious phlegm. And then also check with your pharmacist or doctor. Maybe they've got a great product that they can, I know that I've seen them in the pharmacy. I can't recall offhand, but yeah, there are phlegm busting sort of products that you can get that could help. But I think underlying, if you're not systemically hydrated, if your hydration status is poor, that's probably the number one factor. And also, is there any medication that you're on that is causing dry mouth? So review your medications with your doctor or pharmacist. Say, I'm having this dry mouth, this phlegm problem. Are any of these a culprit, and is there anything that I can do about it?
Great, great. What is the relationship between water and bacteria in mouth, and what is carried to the lungs?
So the water is just the vehicle. So if you have water go down the wrong way, as I said, on a perfectly clean, pristine mouth, you just chug down some water and it didn't go down the wrong way, you're not likely to develop any infection. It's just the bacteria in the mouth. Okay, so I've been asleep all night. I get up in the morning. There's natural bacteria in my mouth. That happens to everyone. And now I take a drink of water. Oops, the water goes down the wrong way. Well, now it's washed with the bacteria, and that makes its way to the lungs, which is the problem. So clean mouth, water, not harmful.
Very important. Gail, I had a question. How do you get a talker to not talk while eating?
Oh, that's a good question.
I don't know. If you can solve that, that would be great.
Oh, that's the $1 million question. Oh my goodness. You know what? Probably that would take, old habits are hard to break. I would bring it to their attention and see if they could. You don't have to be quiet for the entire meal, but you just have to get into the habit of, I'm taking a bite and I'm swallowing. Now I'm going to say something. Now I'm going to converse. I'm going to chat with the people at the table, and then just try to be mindful of that. And if you have a loved one that maybe can give you a nudge and point out when you're not doing it, that could be helpful. But yeah, I get it. That's a hard habit to break. And some people are just really chatty and social when they're eating.
All right, a couple more questions here. I'll group these ones because it's about exercises for making your voice stronger. And then, voice exercises. And then one other person also asked, can you describe us your free trial and continuing cost structure for Get Loud, Stay Loud?
Yes, absolutely. So there are Parkinson specific speech and voice exercises that are kind of universal, and those are the vocalizations. So just taking a nice breath and thinking and being a little bit louder than feels necessary, and holding a vowel for about 10 seconds, 15 seconds, like so projecting your voice across the room. Okay, not screaming, not yelling, but doing that maybe 10 or 12 times in a row and just exercising the vocal muscles. Another good one to do is pitch glides up and down. Because what I'm doing when I'm doing a pitch glide, I'm actually raising and lowering my laryngeal structure. And that laryngeal structure is what raises and lowers when you swallow and you protect your airway. So when you're doing those pitch exercises, you're not just working on intonation in the voice, you're also moving that laryngeal structure that is essential in maintaining a good swallow. So those are kind of the bread and butter ones that are always included. In our program, we of course include those exercises, but we have lots of different approaches and styles of other exercises that we do. The free trial, yes, is for 30 days. And then after that, it's $34.99 a month. And that's unlimited access to 10 different classes a week, all different styles. We have 5 We have 4 speech pathologists, an occupational therapist, and a music therapist on our team that all have different fun, engaging, interesting classes that all work on these things.
That is wonderful. And we have on our website, I just put it in the chat, or it's going about to go in the chat, at apdaparkinson.org/events. There's some Sing Loud and other classes as well that are free online there.
I was going to say, if you can be involved in anything that's musical, if you're in a choir, church choir, a Parkinson's choir, anything, sing in the shower. Singing is the best thing that you can do for your voice. It targets voice, it targets speech, it targets respiratory control, it targets fluency and pacing and rhythm. It's cognitive, it's engaging, and it's social. So if you're involved in anything music or singing based, don't give that up. Keep doing it.
Great, great. Lori says, I know we're running over, but these are really good questions. And I noticed that most people are staying on and holding on to your every word. So we'll just keep going if you're okay with that, Sarah.
I'm perfectly okay with it.
Okay, a couple more questions. From Lori, I've had for 2 weeks a rattle when I breathe laying down. Is that related to what you are talking to us about?
It's hard to say. That's really something you'd have to go to your physician and get checked out. But if that's new, if that's not something that was there prior to 2 weeks, seek out an appointment. It might not have anything to do with aspiration, but it's certainly something that you want to have checked out. And they can, if they do suspect that it is swallowing related and you're having issues, they would, of course, refer you to a speech pathologist for a clinical and possibly a modified barium swallow.
Yeah, always better to get checked out.
Yes, 100%.
Any tips? Dwayne always gets potatoes stuck in his throat and it's painful.
Potatoes, chips, popcorn, peanuts. Those are things that I call dry particulate items. They're really hard because they don't hold their shape. They're not moist, they're not cohesive, and there's little breaky bits. Or granola is sometimes the same thing too. One thing you can try is if you like dip, you could dip your chips in dip to kind of moisten them, or you can make sure that you're alternating. So take a chip, chew and swallow it, take a sip of water. But there are just certain items, and it happens to me too with popcorn. You get that dry little bit in your throat. But yeah, if you like a dip, I don't know if it's diet approved. That's the dietitian's concern. Yeah, just anything you can do to kind of make it maybe a little bit more moist, so that when you chew it up in your mouth, it's a bit less dry.
Good tip. All right, last question. Have you used EMST 150 for patients, and what do you think of that device?
I certainly have. Yes, one of my the last Parkinson's patient that I worked with directly. I don't do direct therapy anymore. I just run the program. But yes, he had an EMST 150 device. He ordered it online and used it every single day. Yep.
Great. Great. Well, that is all the questions we have, Sarah, and good job staying hydrated. Thank you very, very much. Just a reminder to everyone, we will be sending out the slides, the handouts, information about the program, and then our recording will be up on our YouTube page, which I put in the chat, or you can just search for APDA Northwest on YouTube. And subscribe, and anytime we do a program and upload it, it will be up there, and we have lots of good ones in the past. Huge thank you again to Kiawa Corinne for sponsoring this program, and for so many of you who donated to make this possible, and Sarah for joining us all the way from the south of France.
Well, thank you for having me. It's been an absolute pleasure. And if anyone has any questions that I didn't answer or I couldn't, feel free to reach out to me through APDA, and I'm sure Jean would forward those questions on to me.
Absolutely.
If I don't know the answer, I'll find somebody that does.
Great. Thank you so much, Sarah. And thanks everyone for joining us. Take care.
Take care.